Thank you, Joachim. Thank you, Felix, for inviting me. Lovely audience. I'd like to present you our data. And as you've seen, I'm just a simple-minded heart surgeon running on the stage. We are sitting together in our cardiac groups, and we are discussing what is the best valve, especially, for example, here in Decellularized follow, in pulmonary position for these patients. And now we have the cardiac team, and we're talking together with the cardiologists and the pediatric cardiologists. And even if we especially if we look at the patients who have been operated 2, 3, 4 times, we often come to this situation that we can insert it in the cath lab, and it's much easier. We do not have to open the sternum. Yeah, but this is our common things. It's not that we see, but maybe it is possible to avoid reoperation. And you have seen the Harden criteria, and the question is it possible to create a living pulmonary valve to avoid reoperation? And decellularized valves provide a suitable environment for this cell migration and enables this tissue reorganization that is necessary for this idea. And I think that this is possible. If you look at the different concepts, you see these are a lot of concepts we've heard of who are now in the animal model or in the labs, but there are some concepts now who are still in patients. Yeah, we have decellularized patches for valve or cardiac reconstruction or vessel reconstruction, and we have valve replacements with xenografts or with this decellularized homografts. If you look at these replacements, and this is what I'm talking about, we see that we have xenografts and the homograft. All these grafts have a disadvantage because deceleration and also cross-linking of xenographic tissue does not eliminate human cell-mediated responses. So we have an immune response. And if you look at this here, this is immune response, for example, here for xenografts, and this is for the decellularized homografts. This is from the work of Vienna from last year. But this is also, if you see, an ex vivo setting. We looked for this in our patients after pulmonary valve implantation, and we haven't seen it as an immune response, but this was after a lung machine operation, and this is a totally different situation. I think we have a reduced immunogenicity also in decellularized homografts. These are the results, what we see, and this is what the pictures are, and these are totally different than other replacement situations. We always have a very good-looking graft that is here well, and also if you look at this growing graft, this is 10 years after implantation into a 10-year-old boy. You see that is well-looking. It's not stenotic, and it's very fine. So I think this only can be in a living tissue. This is a paper we published last year, and this is a paper we had now 93 of these decellularized pulmonary homografts, and we looked at several situations here with bovine jugular veins and with conventional homografts, and we looked how they going in the next 8 to 10 years. And here you see the decellularized grafts, freedom from explantation was 100%, and this with the conventional homografts 84 also with the bovine jugular veins, and freedom from explantation and intervention was 85, and here nearly 80 and 65. So you see also if a matched pair, if you look at matched pairs, that you have a really good graft for that. But if you look at, for example, endocarditis, here we have an excellent graft, and this was surprising because if you implant such a graft, it's decellularized, it had no cells, yeah? And after publishing this in 2016, we haven't seen any endocarditis. Now we have seen in the last year 1, so we are in the normal range. I think there is endocarditis, but this endocarditis, it's focused on the first year, and this is a year you need for recellularization. If you look at how the graft works, here you see freedom from at least moderate insufficiency. There's no advantage in these grafts. It's the same, but I think in most of these grafts, you have not the problem of insufficiency. The greatest problem is stenosis. And if you look at this, you have also a little bit of stenosis. It's here more than 25 millimeters degree, and it's the same as you here see in conventional homografts. But if you look at the higher degree stenosis, more than 50 millimeter degree, you don't see, you see a great advantage of these grafts here. So there is only another group, the Da Silva group in Brazil, who is working with this, and these are the results 2017 published in a group of children with congenital heart disease. The median age was 12 years, and here you see the same. At 5 to 6 years, you have an insufficiency of 75. It's nearly the same we had, and stenosis of 85%. And as you look at the pictures here, they're also looking very, very good. So if we can conclude this, I think the decellularized pulmonary homograph is now the best graph we have if we look at the midterm performance. But if I say this is an ideal graft, why don't we have ideal results? We have only 75%, we have 84%, and it is really a living valve for excellent lifetime. And if we say, okay, this is an ideal valve, we can ask, is this an ideal patient or is this the ideal surgeon? And let's look at the patient surgery history. We have implanted in Hannover now, up to now, 119 patients, and 110 of these 119 have been reoperated before, and there had been 1/4 had previous conduits. And if you look at the procedure history, you see a lot of procedures before. And if you look at these concomitant operations, we had a lot of concomitant operations. You see 9 pulmonary arterioplasties, tricuspidoplasties. We had a lot of operations at the aortic valve, inclusive David and Jakub operations. And you see that this is not only a valve procedure, a valve replacement procedure, but there are a lot of different procedures we did too. So, and I said, okay, we must have another look at these things. And I think this is the first time I did this, and I have not read any surgical paper. We want to classify our implantation. Yeah? Have we done a good work? This was our aim to do, but sometimes it was not so good, and sometimes it was bad. Yeah? And can we manage this? And we looked at these patients, and we see here in our patients, in a lot of patients, we can do a good work according to peak gradient, but in 20 patients, we had a gradient more than 20, and there had also been some patients after operation, immediately after operation, had a gradient of 50. And also, if you look at regurgitation, there are patients who had a mild insufficiency. So, in the idea was, if we cannot have an ideal situation, this must have an impact on the development. And if you see development of this valve, and you see if you have a good implantation, you have the best results, and not so good implantations, and even bad implantations, there's a bad outcome for this. And if you look at this, now in what patients we can achieve good results. And here, let's look at the transposition heart. You can have, we had only 33% of good results. And for example, in the TOF group, we have 80% of these results. And if you look at these diagnoses and the development between these diagnoses, the worst diagnosis was a TGA patients and pulmonary atresia. Surprise, surprise. We cannot heal this if we put in a pulmonary valve. But if you have pulmonary valve problem with pulmonary insufficiency or pulmonary stenosis isolated, we have ideal results. So I think that's very simple, but that's very important for this. If we implant this valve in a situation where the valve problem is only part of the problem, yeah, we cannot have good results. So that's what the conclusion is. The use of regenerative implants need to have corrective surgery, and we must rethink what is really corrective surgery in this. And yesterday you talked about your realigning stitch and so on, and these are the ideas we need for this regenerative medicine and also for repopulation of these valves. Yeah? And the last question, I cannot conclude, but is always asked is, do they really grow these grafts? This is what we are, what we measured over the time, and we called it an adaptive growth, because you see, you have a pulmonary artery, it's much too small, it's much too large in Z scores, but then it's coming into Z plus minus 2 or minus. And if you also look at the Dacaster group, it's the same. They implanted it here, and you see the patient's BSA is increasing, and you see that there's an adaptive growth of these valves over time here over 7 to 8 years. So I think there must be a living tissue there. Now we are preparing a paper with the histological results of our explantations, but the explantations are only the bad ones. But we have some where we can show, I think, that there's really living tissue for that. And then I want to say thank you, and this was a surgical talk without any bloody picture. So if you need some bloody pictures, I want to invite you here to Barcelona, 6th of November, where we do a surgical workshop for decellularized grafts. Thank you very much.